I am going to be a part of this. This series is not a part of me, but I have been working with Dr. Khan since last 1 year as an attending. And this is his when he was working in Southampton. But they have requested me to because unfortunately they could not make up. So I would be talking about this case. This is a study, what Dr. Emmer spoke to me before coming over here. He said it's a self-explanatory study. Let's see. To compare outcomes, anterior versus posterior approach, VATS major pulmonary resection. What anterior and posterior actually meant is whether surgeon is in front of the patient or behind the patient. Where McKenna popularized this study in US with the anterior approach, and the Wilwalker's approach was the posterior approach, where the surgeon used to stand posteriorly. It's not moving.
Can you advance? Yeah.
Yeah. Methods, this was a database which was retrospectively studied. Posterior approach was done in 2005 to 2010, which they had a learning curve during this period. And anterior approach was a surgeon who came later and joined them. That study was, a database was 2010 to 2013. Comparison is made between the two approaches only where the data was thought to be more compatible and standardized. Anatomical hilar structures dissected, operating via monitors, and no risk spreading was done. This is results of the pre-operative data. The octogenarians more than 80 years were more in the posterior approach, and PS was in less in the anterior approach. We see the outcomes, how it happened, is there was no mortality in 30 days in both the approaches. Stay was almost the same. Conversion rate was more in the posterior approach. The time taken by the posterior approach was more. And the more it was the SDU stay was more in the posterior approach because the age group was 80 people were more in the posterior approach. So which lobe is the quickest to remove? Right upper lobectomy, left upper lobectomy, right lower lobectomy, and left lower lobectomy. Left lower lobectomy was the fastest to be removed. But there were where the bilobectomy or middle lobectomy was involved, almost the same time was there. Why is anterior approach quicker? What Dr. Emmer felt there was a posterior approach was slow because there is a reason they were in the learning curve. The team was whole as a learning curve. And this was a retrospective study, and they could see that they did all the systematic nodal dissection, whereas the anterior was only random sampling. Anterior, they had used Alexis device, where they was used to stitching, and rest, almost the same thing. And the good part was anterior approach, the uniportal operating was possible. In mitigation, posterior approach operating times included learning curve of surgeons and theater nurses, 2005-2010. Further, a learning curve included for systematic nodal dissection for 2007-2010. Message from him: both anterior and posterior approaches are equally safe in VATS pulmonary dissection. The anterior approach seems to be faster, especially for upper lobes. The posterior approach is threatened with extension if he doesn't rejuvenate himself. There's more than one way to skin a cat. There are more ways of killing a cat than choking it with cream. There are more ways of killing a cat than by choking it with butter. There are more ways to saying the same proverb. That's it, sir.
Thank you. Have questions? Why do you think the surgeon switched from systematic mediastinal nodal dissection to random nodal sampling?
I think the anterior approach, this was a retrospective study. There would have been a systematic nodal dissection also, but the study which they had compared was kept in this because they had statistical data which they had compared. But systematic nodal dissection would have been possible. And if you talk about, there is another lobe-specific nodal dissection.
And I think it's important to make a distinction between random nodal sampling, which implies that you just pick a node when you see one, to a systematic nodal sampling.
Or you are doing a particular lobe, and you took that part of the lobe. So that goes into lobe nodal dissection.
Dr. Fernando?
Yeah, on the first presentation,
yeah.
If I read the slide right, you were removing tubes when the air leak fell below a certain level, but you were still removing the tubes with a measurable air leak. Is that correct? There was a threshold level that when it fell below a threshold level, you felt it was safe to remove the tubes. Where there's time that the chest tube, or time after the pleurodesis come into effect, because my guess is if you have a persistent small air leak and you pull a tube out early, the lung's more likely to drop. If there's, then maybe if you waited for a few days.
So that's why we are doing pleurodesis for that.
Right.
We are doing pleurodesis for this reason, same reason. What we are trying to put up is we are doing pleurodesis for the sick patients which we cannot. We pull up the lung and then we do the pleurodesis.
Right. So at what time point? So would you wait, if you had a persistent air leak and it gets to a certain level, would you be comfortable in day one pulling the tube out, or would you wait for 2 days before pulling the tube out? Or
it depends upon the kind of air leak it was. If it was a huge air leak or the lung came up early with 24 hours of this machine, and then we install the talc, we see what is the trend of the air leak in 24-hour recording, and accordingly we decide.
Okay.
Because the recording shows the kind of leak. If the leak is constant, like up to 50 ml, we will follow. Or if there is a leak which has been variable, like 100, 200, 300, and 150, so we wait for another 24 hours, and then we remove it.
Right, but we all see these patients who you question whether there's an air leak and we don't have the electronic chambers in our institution, or maybe there's like an occasional something, or you look at it, or you even think that it's safe, and you pull the tube and the X-ray's fine, and the patient comes back a day later and the lungs dropped, and they obviously had a small air leak. So I just wonder at which point does it become safe to pull a tube out when you know that you've got an instrument now that's telling you that you have an air leak?
I showed you that there were 2 cases in which we had an apical pneumothorax. Okay. Basically, after even the air leak remained constant, but there was an apical pneumothorax in the X-ray. So we just decided to come out, and we waited till, like, if there is any change in, we kept the patient for 24 hours without the drain, and we repeated in another X-ray. If there was no change in the pneumothorax or the apical pneumothorax, we discharged the patient and asked him to follow up early.
Can I see a show of hands of who uses a digital suction device in their practice? Thank you.
Well, Ricardo from Brazil. We are both from countries that the cost is a big issue sometimes.
Regarding this digital suction machine?
The costs of the digital drain in Brazil, they are really high. And the one time they were asking me if we should get that or not in the hospitals, and my colleagues are all saying for the safety issues that it will be safer somehow. I don't see how this digital drain will be safer than the simple. I think I have a lot of comfort to use. I think I have other ways to sell the thing that you don't need to say that's safer. And your title say that you avoid surgery by using the digital drain. How exactly did you avoid surgery?
The first thing of being safer is there is no variation.
Before the digital drain, you have more surgeries they were doing because you didn't have the digital drain. Yeah. Can you tell me a little bit more about that? What the case they're doing surgery that you avoid because you put the digital drain, not only the suction, the wall, something like that?
See, what we have chosen the patients who were not fit for surgeries. If any patient we are operating also, any major cases other than the smaller cases, if you are doing any wedge biopsies and all those things, we are not placing a drain. digital section. But in case of we are doing lobectomies or any cases of robotic surgeries, or we are doing any decortication, we place a drain. Okay, a digital section, because it keeps a constant pressure, which is more easy to watch. The air leak is always recorded. We have an understanding that what we are monitoring for 24 hours is correct or not. Where else, when we come in how many times we take a round in the hospital to monitor the three digital conventional method, we depend upon the paramedics. They say this is the leak. We see the X-rays. We might have to wait further. That increases the stay of the patient. Probably when there is a constant pressure, we are sure that we are not putting any different pressures in the different time. And the patient can be mobile earlier than what we may place a conventional drain. I feel that.
I had some experience with the Digivent system probably about 6 years ago. It was the first system. And it was interesting, their flow meter or flow leak never read 0, because whatever came out of the tube, fluid or air, would be measured and would generate a volume or quote-unquote air leak. But they were able to measure the intrapleural pressure, and there was a time period where you could see the intrapleural pressure become more negative and the flow rate come down, and there would be this intercept where you could say, great, I've got a very little leakage of air and reestablishment of pleural pressure. Do you guys look at that? Because I'm not sure this could ever tell you, I got 0 leak.
So we are constantly monitoring the X-rays. At the same time, the kind of air leak. And that makes us more comfortable to decide and at the same time, clinically, we can decide how the patient is behaving.
So we have to move on to the next presentation. Perhaps if there's some time at the end, we can have some additional questions.